In a world absolutely swamped with information. I mean, one study says this, another says the exact opposite. Headlines changing constantly. How do you even figure out what you can actually trust? How do you stay truly informed?
Yeah, it's a huge challenge, isn't it, for everyone? That
Hmm.
overload, it's not just noise. It makes making really sound decisions incredibly difficult, whether, you're a researcher, a policymaker,
Or just anyone trying to understand health claims online.
exactly, or claims about anything, really.
Right. And that's precisely why we need, well, powerful tools to cut through all that static. Our guide today is a fantastic look at one of the most respected tools for doing this, for synthesizing knowledge, the systematic review.
hmm It's often called the gold standard, and for good reason. It's
Yeah.
about bringing evidence together in a really rigorous, unbiased way.
So our mission for this deep dive, then, is to really unpack what a systematic review is, why it's earned that gold standard reputation, and sort of walk you through the core process based on this beginner's guide we've been digging into.
Yeah, think of it as a roadmap.
Exactly. A shortcut to understanding how robust evidence is actually built, whether you're doing research, making policy, or just want to know how we know things.
And once you get the hang of this process, you'll be much better equipped to evaluate all the information, well, flying at you every day.
All right, let's jump right in then. What's the sort of fundamental idea? What is a systematic review at its core?
Okay, so the core definition is it's a review of evidence, but it's focused on a really clearly formulated question.
Okay, clear question. Got it.
And it uses systematic and explicit methods, meaning they're planned out, step by step, and totally transparent to find, select, critically assess, and then pull together the data from all the relevant primary research on that specific question.
Okay, systematic and explicit. That sounds like the absolute opposite of just, Googling around or casually reading a few papers.
It really is. And while they kind of got their big start in health research, maybe back in the 70s or 80s,
Right, drug trials and things.
yeah, that was a big part of it. But they've grown far beyond just testing drugs now.
So it's not just comparing like pill A to pill B anymore.
Definitely not. Systematic reviews are used across a huge range of topics. I mean, this guide mentions everything from evaluating surgical techniques like for knee replacements
Okay.
to looking at psychosocial interventions, public health programs like um, mobile health apps,
Mm-hmm.
assessing adverse effects of treatments, economic evaluations, how accurate diagnostic tests are, prevalence of conditions. The list is pretty long.
So if you wanted to know, say, the best way to help survivors of domestic violence, like an example in the guide, or the most effective approach for managing a specific chronic illness, a systematic review could potentially tackle that.
Absolutely. As long as you can frame a clear, answerable question and then apply this really rigorous, systematic method to it.
Which brings us right to why. Why do we actually need this level of rigor? Why can't I just, read a bunch of studies myself and write up a summary?
Well, partly because the sheer volume of research being published now is just staggering. It's overwhelming.
Information overload.
Exactly. No single person can possibly read, let alone synthesize, everything relevant to even a relatively narrow topic anymore. Systematic reviews are designed to pull all that knowledge together reliably.
Okay.
They're essential for guiding decisions like which treatments should we actually use, which public health policies should we implement, and crucially, for resolving conflicts when different studies seem to point in different directions.
Resolving conflicting evidence, that feels like a really big one.
It is. It's huge. And when a systematic review is done well, it provides the most reliable, unbiased summary of the evidence available on that question. It really forms the bedrock for evidence-based practice guidelines in many fields.
Okay, that makes a lot of sense. Now, this guide we're looking at draws a really clear line between these systematic reviews and more traditional narrative reviews. What are the big differences that someone should know about if they're trying to figure out which type of summary to trust?
Yeah, the differences are pretty fundamental, and they really get to the heart of reliability and, well, trustworthiness. Think about the goal first. A narrative review often gives a kind of broad overview of a topic, maybe based on what the author already knows or found fairly easily. A systematic review always starts with a laser-focused question.
Like, instead of what's new in treating diabetes, it's more like, does drug X compared to drug Y improve blood sugar control in adults with type 2 diabetes? Very specific.
Exactly. And that question in a systematic review is clearly defined right at the start, often using a structured format like PIC2. We can talk more about that later, which really locks in exactly what you're looking for. A narrative review's question can be much, much broader, or maybe not even explicitly stated.
And the people actually doing the review.
Systematic reviews,
Hmm.
almost always done by a team, usually 3 or more people, often bringing you different kinds of expertise, maybe a topic expert, a methods expert, a librarian. A narrative review could easily be just 1 or 2 authors. That team approach is really crucial for quality control and reducing bias.
Right, multiple eyes on it.
Yeah.
Now, here's something you mentioned earlier that sounded really key, the protocol.
This is absolutely central to the whole systematic part. Before you even start searching for studies, you write a detailed protocol. It's basically your blueprint.
The plan.
Your plan, exactly. Outlining precisely how you're going to conduct the review, the question, the search strategy, the criteria for including studies, how you'll assess quality, how you'll synthesize data, everything.
And the crucial part is?
The crucial part is that this plan is decided before you see the results of any studies. This is fundamental for minimizing bias. You can't be tempted, even subconsciously, to change your methods based on whether you like the results you're finding, because the methods are already set in stone.
Ah, okay. You commit up front.
You commit up front, and often this protocol is registered publicly, maybe on a site like Prospero, so everyone can see the plan, and it helps avoid, 2 teams accidentally doing the exact same massive review at the same time.
That makes sense. Okay, what else is different? The search.
Oh, drastically different. The search strategy in a systematic review has to be comprehensive, documented in detail, and designed so someone else could, in theory, run the exact same search and find the same studies. It needs to be reproducible.
How do they make it so comprehensive?
You search multiple scientific databases. The guide suggests at least 2 or 3 is essential, but you don't stop there. You also actively search other sources, including what's called gray literature.
Gray literature.
Yeah, things like conference abstracts, dissertations, government reports, clinical trial registries, stuff that isn't published in the usual peer-reviewed journals, but might contain really important data, positive or negative. A narrative review search might be much less thorough, maybe just keywords in one database, or relying on studies the author already knew, which can introduce bias.
Okay, so a much wider net. And then picking which studies actually get included.
That's based on clear, explicit inclusion and exclusion criteria that you defined back in your protocol. And critically, this selection process, the screening, is typically done by at least 2 reviewers independently.
2 people again.
Yep. They both look at the titles, the abstracts, then the full papers, applying those criteria. If they disagree on whether a study should be in or out, they discuss it, maybe bring in a third person if needed, until they reach consensus. This minimizes errors and prevents one person's subjective judgment from skewing the selection, narrative reviews. The selection can be much more subjective, often without clear criteria stated.
And what about judging the quality of the studies you do include?
Another key difference, systematic reviews involve a rigorous quality assessment, or risk of bias assessment, for each included study. You use standardized checklists or tools appropriate for the study design to look for potential flaws. Narrative reviews might comment on quality, but it's often less systematic or might vary a lot.
It really sounds like every single step is meticulously designed to remove the individual reviewer's potential biases or opinions and just focus purely on the evidence itself.
That's precisely the goal. Even the synthesis, how you summarize the findings, is different. In a systematic review, the summary, which might be quantitative like a meta-analysis if the studies are similar enough, is based directly on the quality appraised evidence. In a narrative review, the summary can sometimes be more influenced by the reviewer's existing beliefs or the story they want to tell.
So overall, the systematic review gives you something far more objective, transparent, reproducible.
And generally more trustworthy, yes, assuming it's done well, of course.
You mentioned scoping reviews briefly. How do they fit in? Are they just like a quicker version of a systematic review?
Not exactly quicker, but they serve a different purpose. A scoping review is often used when you want to map out the extent, range, and nature of research activity on a topic. Maybe the area is really broad or it hasn't been reviewed systematically before. It identifies what's out there, rather than answering a very specific effectiveness question, like a typical systematic review. So, different goal.
Okay, got it. So let's say we've decided a full systematic review is what's needed. How do you even get started on something that sounds, frankly, quite daunting?
Well, the first step, as we touched on, is recognizing it's almost certainly not a solo mission. You really need a team.
Right.
The guide emphasizes bringing together people with complementary skills. You need someone who's an expert in the actual topic, sure, but also someone skilled in information retrieval, like a librarian who knows how to design those complex search strategies. You probably need a methodologist who deeply understands the systematic review process itself, and maybe, depending on the data, a statistician.
So a mix of content knowledge, search skills, methods knowledge, and stats.
That's often the ideal mix, yeah. And then once you have your team, the very next step is developing that critical protocol.
The detailed plan, written down before you start.
Exactly. It forces you to think through every single step up front, make decisions explicitly, and that really helps ensure transparency and reduce the potential for bias later on. And as we said, registering it publicly on something like Prospero is best practice, makes your intentions clear, and helps avoid duplication of effort.
Makes sense. The guide also mentions involving stakeholders. What does that mean here?
Yeah, this is about ensuring the review is actually relevant and useful in the real world. Stakeholders could be policymakers, healthcare providers, patient groups, community members.
People who might actually use the findings.
Exactly. Getting their input, maybe when framing the question or deciding which outcomes are most important, helps ensure the review addresses things that matter to them. It connects the sometimes academic process to practical needs.
And I'm guessing with potentially thousands of studies to sift through and all this data, you need some tech support.
Oh, absolutely. You couldn't realistically do a large review without it these days. Specialized software is used at various stages, things for managing references, platforms designed to help the team screen titles and abstracts independently, tools for data extraction, and statistical software for analysis.
So specific tools for the job.
Definitely. They don't replace the human judgment, but they streamline the workflow and help manage the sheer volume of information.
Okay. So team assembled, protocol written and registered, stakeholders considered, tools ready. That's the groundwork. Now, let's get into the weeds actually building the review. Where do you begin once the plan is locked?
The single most critical step, and often the most difficult according to the guide, is structuring that really focused review question we talked about earlier.
Why is it so critical?
Because that question dictates everything that follows, every single step. It shapes your search strategy, what terms will you use, it defines your inclusion criteria, which studies are relevant, it determines what data you need to extract from those studies, and ultimately it guides how you synthesize and interpret the findings.
So if the question is vague or poorly defined,
the whole review will likely be flawed or unfocused. It's the foundation. The PICO framework is often used here, especially for questions about interventions.
PAO, remind us what that stands for.
Sure. P is for population or problem. Who are we interested in? I is intervention. What treatment or program are we looking at? C is comparator. What is the intervention being compared to, like standard care, another treatment, or placebo? And O is outcome. What effects are we measuring?
Could you walk through that domestic violence example from the guide using PICO?
Yeah, absolutely. So the general topic is support for women experiencing domestic violence. To make it a focused PAO question, you'd frame it something like this. For women who have experienced domestic violence, that's the P population, how effective are advocacy programs, the I intervention, compared to usual support services or no specific program, the C comparator, in improving their safety or quality of life, the O outcomes?
Okay, that makes it crystal clear what you're looking for and what you're comparing.
Sure.
Very specific.
Exactly. And while PICO is super common for intervention questions, the guide points out there are other frameworks too for different types of questions, like PICO for exposure studies or SPIDER for qualitative research. But the core principle is always the same. Start with a clear, well-defined, answerable question.
Question locked. Next up, finding those studies. You said it's comprehensive. How does that work in practice?
Right, this is the systematic search phase. The goal is to find all potentially relevant studies, published and unpublished, to minimize bias. It starts with brainstorming all the different ways researchers might talk about each component of your PICO question.
So synonyms and related terms.
Exactly. Keywords, synonyms, maybe different spellings, brand names versus generic names for drugs.
Yeah.
You build lists for each PICO element. Then you use what are called Boolean operators, basically logic terms like AND or R, not to combine these terms into complex search strings. You use or R to group synonyms together, like domestic violence or intimate partner violence. And you'd use A&D to combine the different concepts like population terms and intervention terms and outcome terms.
So woman or female, ND, domestic violence or partner abuse, ND advocacy program or support service, something like that.
You got the idea. It gets quite complex. And then you take these carefully constructed search strings and run them across multiple electronic databases, Medline, Embase, PsycInfo, SinaHL, Cochrane Library. The guide stresses using at least 2 or 3 relevant ones as a minimum.
And the gray literature, too.
Yes, plus actively searching for gray literature. That might involve searching Google Scholar, Specific repositories like OpenGray, websites of relevant organizations, trial registries, conference proceedings, contacting experts.
Wow.
It's a detective work phase. And you had to slightly adapt your search strategy for each different database because they all have slightly different syntax and indexing.
That sounds incredibly painstaking.
It is. But it's crucial for comprehensiveness. And transparency is vital here, too. You meticulously document every search you run, exactly how you ran it, how many results you got from each source. This all gets reported, often using a standard flowchart called a Prisma diagram.
Prisma?
Yeah, it stands for Preferred Reporting Items for Systematic Reviews and Meta-Analyses. The Prisma flow diagram visually maps out the whole process. How many records you found initially, how many duplicates were removed, how many were screened, how many full texts were assessed, and how many studies were finally included, along with reasons for excluding others. It shows the reader exactly what happened to all the potential studies.
Okay, so you've done this massive search. You've got potentially thousands of hits. How do you sift through them to find the ones that actually fit your question?
This is the study selection phase, and it usually happens in at least 2 stages. First, those 2 independent reviewers we talked about screen all the titles and abstracts identified by the search. They apply the predefined inclusion and exclusion criteria from the protocol.
Just based on the title and abstract?
Initially, yes. If a record clearly doesn't meet the criteria, it's excluded. If it looks potentially relevant, or if there's any doubt, it moves to the next stage.
Which is?
The full text screening. Again, 2 reviewers independently rate the entire article for every potentially relevant record. They apply the inclusion and exclusion criteria much more rigorously now they have all the details.
Yeah, they have to agree.
They discuss any disagreements. If one reviewer thinks a study should be in, and the other thinks it should be out, they go back to the protocol criteria, discuss their reasoning, and try to reach consensus. Sometimes a third reviewer might arbitrate if they can't agree. It's all about ensuring that the final set of included studies accurately reflects the criteria without bias.
Okay, studies selected. Now you need to get the actual information out of them, right?
Exactly. That's data extraction, sometimes called data abstraction or coding. You use a standardized form, one that you've designed based on your protocol, and ideally pilot tested beforehand, to systematically pull out all the key pieces of information from each included study.
What kind of information?
Things like details about the study itself, author, year, design, setting, characteristics of the participants, age, sex, condition severity, specifics of the intervention and comparator, how the outcomes were defined and measured, the main results, funding sources, basically anything you need to understand the study, assess its quality, and potentially include its results in a synthesis or meta-analysis.
And let me guess, 2 people doing this independently.
Best practice, absolutely. 2 reviewers extract the data independently using the same form. This helps catch errors or misinterpretations. They then compare their extracted data, resolve any discrepancies. The form itself can be quite detailed, and you need to be clear where in the original paper you found each piece of data. Sometimes you might even need to contact the original study authors if crucial information is missing.
Wow, the level of detail required for each individual study sounds intense. Okay, so you've got the data extracted. What about judging how good each study actually was? The quality assessment.
Yes, that's critical appraisal, or assessing the risk of bias. This isn't about whether you like the study's results. It's about judging how trustworthy those results are, based on how the study was designed and conducted. How much confidence can we have that the findings aren't seriously flawed?
How do you do that systematically?
It's a standardized process. Reviewers use specific tools or checklists that are designed for the type of study they're looking at. There are different tools for randomized controlled trials, cohort studies, diagnostic accuracy studies, etc. These tools guide the reviewers to look for specific potential sources of bias.
Like what kinds of bias?
Common ones include selection bias was the process of allocating participants to groups truly random, or could it have been manipulated? Performance bias, did participants or researchers know who got which intervention, potentially influencing behavior or care? Detection bias, were the outcomes measured differently or more carefully in one group than another? Attrition bias, did more people drop out of one group, and could that skew the results? Reporting bias, did the study authors only report favorable or statistically significant results, ignoring others?
So you're basically probing for potential weaknesses in the study's methodology that might cast doubt on its findings.
Precisely. You're assessing the internal validity. How well was this particular study done? And again, this critical appraisal is typically done by two independent reviewers using the same tool with discussion to resolve disagreements to ensure it's robust and consistent.
Okay, this is a lot of steps. So now you've got your selected studies, you've extracted the key data, and you've assessed the trustworthiness or risk of bias for each one. How do you finally bring it all together to answer your original review question?
Right, this is the synthesis stage. How you synthesize depends on the type of data and the similarity of the studies. For intervention reviews looking at quantitative outcomes, a widely used system for summarizing the overall strength of evidence is called GRADE.
Grade. What's that?
It stands for Grading of Recommendations, Assessment, Development, and Evaluations. It's a transparent framework for rating the certainty or quality of the body of evidence for each important outcome you defined in your PFO question.
So not just the quality of individual studies, but the quality of the evidence overall for a specific outcome across all the studies.
Exactly. GRADE assigns one of four levels of certainty: high, moderate, low, or very low.
And what do those levels mean?
High certainty means we're very confident that the true effect is close to the estimate from the review. Moderate means we're moderately confident, but the true effect might be substantially different. Low means our confidence is limited, the true effect might be substantially different, and very low means we have very little confidence in the effect estimate. The true effect is likely to be substantially different.
How do you decide which level applies? Doesn't evidence from randomized trials usually start high?
Yes, evidence from randomized trials typically starts as high certainty, and evidence from observational studies starts as low. But then that initial rating can be downgraded based on several factors across the body of evidence for that outcome.
Downgraded. Why?
Well, you might downgrade if there are serious concerns about the risk of bias across many of the included studies, or if the results are very inconsistent from one study to the next, what we call heterogeneity, or if the evidence is indirect, maybe the studies used a slightly different population or intervention than your PACO question specified, or if the results are imprecise, maybe because there are few studies or small sample sizes leading to wide confidence intervals, or if there's a strong suspicion of publication bias that studies with negative or null results were less likely to be published.
Okay, so grade takes into account not just the study design, but all these other potential issues across the studies to give a final confidence rating.
Exactly. It helps you communicate not just what the evidence suggests, but how confident you can actually be in that overall finding, and importantly, why your confidence is at that level.
And how is this presented?
A key output is often a summary of findings table. This table clearly presents the main results for the most critical outcomes, shows the estimated effect size, like a risk ratio or mean difference, and explicitly states the grade certainty rating for each outcome, often with footnotes explaining any reasons for downgrading. It's designed to be a concise, informative summary for decision makers.
What about meta-analysis? You hear that term a lot with systematic reviews. Is that part of grade?
Meta-analysis is a specific statistical technique that can be used within the synthesis phase of a systematic review, but it's not grade itself. It's the process of quantitatively combining the results from multiple similar studies.
And why would you do that? What's the point?
The main goal is usually to increase statistical power and get a more precise estimate of the overall treatment effect. By pooling the data from several studies, you often get a narrower confidence interval around the summary result than you would from any single study alone.
But you mentioned earlier it's only done if appropriate. What makes it inappropriate?
The big consideration is heterogeneity.
That inconsistency between studies again?
Yes. Heterogeneity refers to the variation in study outcomes beyond what you'd expect just due to chance. If the results from the individual studies are wildly different or jumping all over the place,
Then maybe combining them statistically doesn't make sense.
exactly. It might be misleading to calculate a single average effect if the studies are fundamentally too different. This variation could be due to real differences in the participants studied, how the intervention was delivered, the outcomes measured, the study designs, or the quality of the studies.
So how do you know if there's too much heterogeneity?
There are statistical tests for it, like the I-squared-I statistic, which estimates the percentage of total variation across studies that is due to heterogeneity rather than chance. A high I suggests substantial heterogeneity. There are also graphical ways to explore it.
Like those forest plots you sometimes see.
Precisely. A forest plot is a great visualization. It typically shows the result, like an odds ratio or mean difference, and its confidence interval for each individual study included in the meta-analysis, plotted as squares and lines. Then at the bottom, it usually shows a diamond representing the pooled overall result from the meta-analysis and its confidence interval. It lets you see the results of each study, how much they vary, and the summary estimate all in one picture.
Ah, okay. That helps visualize it. So if heterogeneity is really high, you might decide not to do a meta-analysis, even if you have multiple studies.
Correct. In that case, you might present the findings using a narrative synthesis, describing the results of the individual studies and exploring the potential reasons for the variation without calculating a single pooled number.
Got it. Okay, let's circle back quickly to the software you mentioned way back at the beginning. How does that actually fit into executing all these incredibly detailed steps?
Yeah, the software is pretty indispensable for managing the workload efficiently and transparently. There are different types of tools used at different stages.
No.
Well, you've got reference management software like EndNote or Zotero to handle the thousands of search results initially. Then there are specialized systematic review platforms. Some popular ones mentioned in the guide are Covidence and Rayan. These are designed specifically to help the team manage the screening process, title, abstract, and full text, collaboratively but independently. They often track who did what and help resolve conflicts.
So they manage the workflow for the reviewers.
Exactly. Ryan is often highlighted as being free and having a mobile app, which can be handy. Covidence is widely used, especially by Cochrane review groups. Other tools like EPI Reviewer or Distiller SR offer even more features, maybe covering data extraction and quality appraisal too, sometimes with AI assistance, but might have costs associated. There are also free web-based options like Kadima or Sistra have mentioned.
And for the actual meta-analysis part.
There's specific statistical software for that. Revman, Review Manager, is the standard tool used for Cochrane reviews. But you could also do meta-analysis using statistical packages like Stata or R, or even specialized Excel add-ins like Meta Essentials or Meta Excel. So lots of options depending on needs and budget.
Okay, it sounds like there's a whole ecosystem of tools to support this rigorous process. So finally, you've done it all. Question, search, selection, extraction, appraisal, synthesis, maybe a meta-analysis. You've written it up? Is that the end?
Almost, but not quite. A systematic review, no matter how well done, only has an impact if the findings actually get out there and are used. So the final crucial stage is dissemination.
Sharing the results.
Sharing the results effectively. And this might mean tailoring the format to different audiences.
How so?
Well, you'll likely publish the full technical report in a peer-reviewed journal for other researchers, but you might also create a short evidence summary or a plain language summary for patients or the public, or maybe a concise policy brief specifically highlighting the implications for decision makers. The key is getting the right information to the right people in a format they can understand and use.
And making sure the reporting is transparent.
Absolutely critical. That's where reporting guidelines like PRISMA, which we mentioned earlier, come in again, or MOOS for meta-analyses of observational studies. These guidelines provide a checklist of essential items that must be reported in your review, detailing your methods, your search, your results, your grade assessments, everything. Following these guidelines ensures your review is transparent and complete, allowing readers to judge its quality and trustworthiness for themselves.
So they can essentially trace your steps, see exactly what you did, and understand how you reached your conclusions. It closes the loop on that systematic and explicit approach.
Precisely.
Wow, that is quite the journey. It's incredibly rigorous. From starting with that single, tightly focused question, all the way through hunting down everything relevant, having multiple people independently check and assess it, carefully pulling it all together, rating the overall confidence, and then sharing the results transparently.
It definitely requires significant time, resources, and expertise. But when it's done well, as this guide lays out, it really does provide the most reliable, comprehensive evidence base currently available to inform decisions in a world just swimming in information.
And that really brings us back to you, the listener. Understanding this whole process, understanding why systematic reviews are considered the gold standard, it empowers you. It helps you look critically at claims based on evidence, whether it's in the news, from a doctor, from a politician, and ask, okay, how is this evidence gathered? Was it done systematically? Was bias minimized? Can I really trust this summary? It's your shortcut, really, to cutting through the noise and becoming genuinely well-informed.
Knowing what goes into a high-quality systematic review gives you a benchmark, a way to gauge the certainty of the evidence behind recommendations or claims that affect your health, your community, policies, your world.
So here's maybe a thought to leave you with today. Given just how much effort, how much meticulous rigor goes into building this kind of truly trustworthy evidence base, How often do you think the personal choices we make every day, the public policies that govern our lives, the treatments we might receive, how often are they actually informed by this highest standard of synthesized evidence? And maybe more importantly, what does it mean for us when they aren't?